Assalamu alaikum wa rahmatullah. I'm Dr. Iman Atif, lecturer of pediatrics. This lecture is about acute management of seizures. During this lecture, we will have introduction to the types of seizures, pre-hospital management of seizures, and finally, the hospital management of status epilepticus. Let's start by the definition and the types of seizures. The seizure is the clinical event. A seizure is a sudden and temporary change in the electrical and chemical activity in the brain, which leads to change in the person's movement, behavior, level of awareness, and feeling. So it's the clinical expression of the neurologic dysfunction. It's a clinical expression of an episode of neurologic dysfunction. You may hear the term seizure. It's equivalent to the term fit or convulsions, but we usually use the term convulsions when we deal with motor seizures. Seizures can be classified into two types. First, what's called provoked seizures. Provoked seizures mean that there is a direct cause or a direct precipitating factor for the seizure, like fever in febrile seizures, like trauma in traumatic seizures, and some metabolic disturbances like hypoglycemia, for example. The other type is what's called the unprovoked seizures. Unprovoked seizures means that there is no reason detected, and the seizure could be repeated. And this is what's called the epileptic seizures. So the epileptic seizures are those seizures which are unprovoked, and they are only caused by the abnormal electrical discharge from the neurons in the brain. And from this, we can conclude the diagnosis of epilepsy. Epilepsy is the disease that's characterized by presence of recurring seizures or recurrent unprovoked seizures. So again, the seizure is the single occurrence of jerky movements and or other features of fit, while epilepsy is defined by presence of at least two or more unprovoked seizures occurring in an individual. Another important definition is the status epilepticus. When seizures are prolonged more than 5 minutes, they are called status epilepticus, and this is an emergency situation. Here we have a case scenario. While you are studying, your neighbor runs to you because her son is having a fit. He was feverish all morning and temperature was not coming down with acetaminophen. He was playing when he suddenly started staring, eyes are deviated to one side, and all the body jerking. What to do? Here you are confronted by a scenario of a child seizing at home. So the first priority is to keep the child's safety and track the duration of the seizure. As long as the seizure is less than 5 minutes, there is no need to call for an ambulance, and all what you have to do at this time or at this point is to keep the safety of the child. So please put the child in a safe position, like in a side-lying position. Protect him from injury, from falls, protect head from injury, try to loosen tight clothing around the neck, and prevent the child from falling, as I mentioned before, just the reassurance of the child during the event. And so, as I mentioned, as long as the seizure finished before 5 minutes, there is no need to call the ambulance and just place the child in a recovery position. But if the seizure prolonged more than 5 minutes, this is an emergency condition, has to be treated as status epilepticus. For our case, Ali started to wake up. He looks flushed and tired. Mom mentioned that he had one of these before while he was feverish as well. The doctor diagnosed him to have a febrile seizure. So what are the febrile seizures? Febrile seizures are the most common cause of seizures in children between the age of 6 months and 5 years. They are caused or provoked by fever, increase in the body temperature more than 38 degrees centigrade. The fever can be documented before or during or after the seizure. Febrile seizures are benign, and for the diagnosis of febrile seizure, we have to be sure that the fever is not related to central nervous system infection, and there is no metabolic disturbances that can explain the seizures, and there is no past history of seizures without fever. Febrile seizures are classified into two types. There is simple febrile seizures and there is complex febrile seizures. For the simple febrile seizures, all of the following has to be fulfilled, or all of the following has to be present in order to diagnose the febrile seizures as simple. The seizure lasting less than 15 minutes. It has to be generalized in nature and it occurred just once in a 24-hour period. For the complex febrile seizure, any one or more of the following has to be present in order to diagnose it as complex. The seizure is prolonged more than 15 minutes. The seizure is focal. It occurs more than once in a 24-hour duration. Let's move to another case scenario. An ambulance brings a 3-year-old boy to the emergency department with a seizure. He has been seizing for 2 minutes. He was out with his parents when he suddenly stopped, stared, then fell to the ground and started sharing all 4 limbs. There is no vomiting, diarrhea, or rash. The post-medical history is unremarkable. The family history is significant for an uncle who has epilepsy. His examination revealed vital signs. His temperature was 36.8. His pulse was 165. Respiratory rate was 30. Blood pressure was 90/60. And oxygen saturation on room air was 100%. Anterior fontanelle is closed, pupils are equal and reactive, extraocular muscle movements are conjugate, red reflex is present bilaterally, there is no sunsetting of the eyes, his mouth exams show moist mucosa without erythema, Prudzinski and Kernick signs are difficult to assess, respirations are regular, neurologically he moves both arms and legs equally, his tone appears normal, the rest of the examination is normal. Here you are managing a child at hospital. And in hospital management of seizures, always remember that assessment, treatment, and investigations should all go hand by hand. At this point, your initial assessment is targeted to the airway, breathing, circulation, to check the maintenance of the circulation and try to gain an intravenous or intraosseous access. Measure the blood glucose level and manage hypoglycemia if present. You can start antibiotics if you think of some infectious cause like meningitis or septicemia. After the initial assessment of the airway, breathing, and circulation, now you can have a secondary assessment and a focused history of the child's health and activity over the previous 24 hours, or if there is any significant previous illness. All your assessment has to be during the first 5 minutes. If the seizure is prolonged more than 5 minutes, as we mentioned before, you have to start the active treatment. So you have like a time window of 5 minutes during which you can do your initial assessment and the initial supportive measures for the airway, breathing, and circulation, and gaining the intravenous access and establishing some investigations as needed, as blood glucose or whatever the cultures, electrolytes, and so on. After 5 minutes from the onset of the seizure, you have to initiate the treatment. We have the treatment of status epilepticus divided into like 3 lines or 3 phases. The first line medications, which are the benzodiazepine. You can give midazolam or diazepam. Midazolam can be given intravenous, or if there is no intravenous access, it could be given like intramuscular or intranasal or buccal route, while diazepam could be given intravenous, or if there is no intravenous access, you can give it perrectal. After After 5 minutes from the first dose of the benzodiazepine, if the seizure has ended, you can put the child in a recovery position and continue your assessment and investigations. If the child is still seizing after 5 minutes from the first dose, you can give a second dose of benzodiazepine. If the seizure is still present after 5 minutes from the second dose, here you have to shift to the second line treatment. For the second line medications, we have multiple options. We can use phenytoin, phenobarbital, levetiracetam, or valproic acid. All these can be given by intravenous route. For phenytoin, it's given at a dose of 20 milligrams per kg. It's given as infusion over 20 minutes, but take care that it is only mixed in normal saline. For phenobarbital, it's given at a dose of 20 milligrams per kg, also as infusion over 20 minutes, but it could be mixed in normal saline or in dextrose 5% in water. For levetiracetam, it's given as a dose of 60 milligrams per kg. It's given as infusion over 5 to 15 minutes, mixed with either normal saline or dextrose 5% in water. For valproic acid, it's given at a dose of 30 milligrams per kg. It is given as infusion over 5 minutes, mixed with normal saline or dextrose 5% in water. If the patient is still seizing or the seizure present for 5 minutes after this medication has been administered, you can give a second line medication, another dose of a second line medication. And if he's still seizing after 5 minutes from the second dose of the second line medication, here we can define the status epilepticus as being refractory status epilepticus. You need to consult the pediatric ICU and neurology. Your patient has to be admitted in a pediatric ICU to start anesthetic medication, anesthetic dose of certain medications like midazolam or propofol.